The implantable miniature telescope is a miniaturized version of a Galilean telescope, which is placed inside the eye for patients with end-stage macular degeneration that's stable. It follows regular cataract surgery and we place the device, which is 4.4 millimeters thick, into the bag following removal of the patient's own crystalline lens. It requires a large incision following the cataract surgery out to 12 millimeters, and it's placed in the lens. It should be superseded by an injectable version of the device requiring an incision size of 7 to 7.5 millimeters, reducing the need for that many sutures, and it speeds up the rehabilitation process afterwards. Generally, patients with end-stage stable dry macular degeneration are following a course of anti-VEGF therapy where it's been stable for more than 6 months, they'll benefit from this treatment. The vision should be worse than 6/24 or 20/80 and no worse than 2400 for these patients to benefit. In my experience, patients who've got fairly symmetrical disease will benefit the most, and with a tight small central scotoma. The device works by subtending a magnified image up to 3 times magnification on a preferential looking area just outside the area of disease. It's contraindicated in patients with small anterior segments, such as high hyperopic patients, or those with unstable capsules or zonules, such as those with pseudoexfoliation. We also don't like to put it in patients who've got comorbid diabetic or vein occlusive disease as well. And the fellow eye should have good peripheral vision. We would always advocate a trial of patching for the patient in the eye that's going to be implanted prior to the technique, so the patients don't lose mobility function afterwards. The device itself is very well tolerated. The complications really relate to going back to old extracapsular cataract surgery style with a large incision, and things such as iris prolapse or prolapse of the viscoelastic during the surgery out of the eye, making it difficult to place the device. But once that's been overcome, the device is well tolerated in situ. As I say, it's a contraindicated in patients with shallow anterior chambers because it may damage the corneal endothelium, and indeed you get endothelial cell loss up to 20% at 3 months and 25% at a year in this device. That should be offset by the use of the injectable telescope, which sits further back and gives a larger or deeper anterior chamber depth following the surgery. The most common complication is postoperative intraocular inflammation, and that's managed with topical steroids. It's very important that patients are motivated for the surgery in the first place and that they have good support at home. That is a key point with assessing any patient for the surgery, and that they will follow up with the 6 months of rehabilitation afterwards. There's no point in having this device and not using it. It's the equivalent of having a Ferrari in your driveway and just not taking it out for a spin. So the patients need to be supported and motivated to do it. When they attend the rehabilitation, they're trained back up how to use the device, how to use that magnified image and suppress the other image, and then likewise flick from the magnified image back to the normal peripheral image when they want to mobilize around the place. That is a key issue with rehabilitation with the IMT device.